Good morning, everybody. Welcome to the 6th Annual Aphasia Conference, the ongoing journey living with aphasia. Next page. There we go. I am Janice. I am the president and founder of Just Ask. I had my stroke at the age of 48, and now I'm thriving with aphasia. We started this conference when I had my stroke because I didn't think anybody should have to pay to learn more about their own difficulties and living with aphasia. And if I could have 400 people, if I could have 40 people attend at my public library, I thought my job was done. We had almost 100 people in attendance. And I am just so amazed that we had over 200 people this year register for the conference. So thank you all for attending and continue to thrive and to educate people about aphasia. We could not do this without the Department of Health. We were able to do this and not charge anybody for their sponsoring our services and for this conference. And we've been supported by National Aphasia Association. So thank them all for what they do to help us. Thank you. I'm going to give an outline of the program. We did break this down into 4 different sections because I think that's more digestible for me as somebody living with aphasia. And I think people should not spend a beautiful Saturday in a conference all day. So we will break it down to 9 o'clock. We do our welcoming, 9:15 to 10:30, our guest speaker. Then 10:30 to 11, we'll do the Q&A. We've given a little additional time should we have any technical or things carry on a little bit, but we will be closing the door at 11:30, the latest. It'll be every Saturday in the month of June. So this is our first one. So the rest of June, because it's Aphasia Awareness Month, we have some amazing guest speakers. And I'm going to take it over to our first guest speaker. This is Kait Moses, and she's also runs our Aphasia Social Network group on Monday nights. Thank you, Kait.
Of course, Denise, thanks. Good morning, everyone. I hope you all have your coffee or beverage of choice this morning. I'm gonna just take a moment to share my screen. Can I get a thumbs up? Can everybody hear me okay?
Yep,
Awesome.
absolutely.
All right. And is everybody seeing what I'm sharing? Great. Okay. Well, welcome. Happy Saturday. You made it to the weekend. My name is Kait Moses, and this is just a little disclosures to start us off. So, as Denise mentioned, I'm going to kick off our aphasia conference today, and I am a speech language pathologist and also a board member of Just Ask, as well as a board member of another amazing nonprofit that's also run and led by people with aphasia called National Aphasia Synergy. I'm the owner of Moses Center, and prior to providing services through that, I provided intensive speech therapy through the University of Michigan Aphasia program for almost the first 10 years of my career. So I'm excited to be here with you all this morning. Let me see if I can get my slides to move here. There we go. Denise already gave a little bit of a intro about Just Ask, but I thought I would give a little more background for those of you who are just joining us. Just Ask is a nonprofit organization that's dedicated to spreading awareness and sharing information about aphasia, stroke, and TBI. As Denise mentioned, it's founded by her, who is a stroke survivor herself and aphasia thriver. And this is a great shot of her and her husband, Ken, living their life post-aphasia. In 2019, Just Ask held the first ever aphasia conference in Rhode Island driven by Denise's determination to offer free opportunities for people with aphasia and their families to learn more about aphasia. If you don't know, the ASK part stands for aphasia stroke knowledge. Just Ask as a group runs as a small board and a group of very dedicated volunteers, most of whom have aphasia themselves. And they've done things like presenting at hospitals throughout Rhode Island. They help educate and spread awareness as aphasia or about aphasia, as well as supporting people with aphasia and promoting their independence and just spreading awareness. So they do things such as hosting this conference. Just Ask also distributes these aphasia welcome packets that you can kind of visualize here. They usually include a boogie board, an aphasia visor card, and other aphasia awareness items. If you are ever looking for more information, here are the websites, Facebook pages, and social media Instagram handles for Just Ask. And so today we're kicking off the 6th annual Aphasia Conference. And as Denise mentioned, the theme this year is the ongoing journey living with aphasia. And so today I'm going to start kicking it off with kind of the initial phase and what that looks like, and maybe some essential insights, many of which you all might know. Some might be refreshers, some might be information that was missed during that time of crisis. And so today the goal is just for us to share together some general basics, go over some terminology that maybe you've heard throughout your medical care that you weren't sure what it meant or were never gotten the chance to have a discussion about it with some of your healthcare providers. And then talk a little bit about what this looks like and maybe feels like at the beginning of an aphasia journey. So in the audience today, I know we have a really fun mixed group. We have hopefully a big turnout of people with aphasia and their family members and friends. We have hopefully some professionals and healthcare workers present. And so I just wanted to post an agenda. I'm going to start with doing kind of an Aphasia 101 crash course. And then hopefully about an hour in, I want to do just a 5-minute brain break. So people can get up, stretch their legs, refill your coffee, use the restroom, do whatever you need to for a couple minutes. And then we'll dive back in with kind of key questions, takeaways, and some resources. So I know neurofatigue is a real deal, so feel free to check in anytime or check out anytime. And then we'll end with Q&A, of course. All right, so here is our first stop. Many of you might remember that moment, a near fatal, pretty life-altering event that occurred in your life. It's chaotic. It's unfamiliar territory for you and your family and your loved ones, and everyone is in survival mode. And during this time of crisis, you cannot communicate. And you just heard someone use the word aphasia. Uh-Faze-What? What did they say? You're being told you may never speak, walk, drive, or work again. And so your world, as you know it, has been flipped upside down. I know many of you experienced this firsthand and are probably very familiar with this term now. But before we deep dive into it, I just want to give a basic definition in case any of you are new to joining the aphasia community. So when we talk about aphasia, we are referring to a communication disorder, and it affects how one processes and uses language. It can directly impact speaking, understanding spoken words, reading, writing, sometimes numbers, and most definitely largely affects most aspects of a person's life. Aphasia, as many of you probably experience, can be significantly worse when stressed or you're tired or when you're under pressure, maybe when you're in noisy environments. It can be any combination of deficits in these areas, and it can vary from day to day. And so when we're talking about language, just really basically, oftentimes we think of language as just speaking. And I know society puts a lot of heavy pressure on kind of basing intellect and intelligence off of what you can say. But when I refer to language throughout this presentation today, we're looking at all modalities. So we're looking at reading, writing, speaking, and listening. We can look at language broken into a couple different sections. So we can look at written language versus spoken language, or maybe how it's processed versus how it's expressed, how we use these modalities to understand information, to share information, and express our thoughts. And so another way to look at aphasia is as a language accessibility issue. Oftentimes, people with aphasia know what they want to say. They can easily conceptualize the thought or visualize the idea, but they're unable to access the right words or terminology, or maybe connect the language in order to express it. And it's important to acknowledge that what aphasia is versus what it's not, right? It's not memory loss. It's not a lack of knowledge. It's not a cognitive impairment. It's not a hearing impairment. It's not blindness. It's most certainly not stupidity, and it's not a developmental delay of any kind. It's an acquired accessibility issue due to a brain injury. And it's really important to acknowledge this and the frustration, anxiety, stress, or maybe even embarrassment that someone might feel being unable to suddenly not speak or read or write as they once did. So, as a society, I'm sure many of you have experienced the unfortunate misconception that fluent and eloquent speech is a sign or a measure of a person's intelligence, which we know is not true. So the majority of society has never heard of aphasia. According to a national survey given by the National Aphasia Association in 2016, about 85%, or a large majority of society had never heard of the term aphasia. This number has thankfully changed due to an increased exposure to stories such as Bruce Willis and other celebrities that have been spoken about recently. Unfortunately, sometimes this has led to a really misunderstood definition of what aphasia is, but slowly but surely we're gaining a little bit more awareness and a better understanding of the fact that there are different types of aphasia. And we're going to, of course, talk about that a little bit today. But in general, that lack of societal awareness creates a very misunderstood, inaccessible, and often painful public environment for persons with aphasia to navigate as they experience a lack of communication ability as their new normal. So speaking of Bruce Willis and looking at, all the press that went on about his diagnosis of primary progressive aphasia, we're going to talk about how aphasia is not the same for everyone. Of course, everyone is very, very different, and aphasia looks and sounds different. even if two individuals have the same type of aphasia. I've heard many brilliant people tell me in the past month or so, when you've met one person with aphasia, you've met one person with aphasia. And we're going to talk about that today and kind of dive into more what the different aphasia types might look like, and more appropriately, what aphasia can be and what you need to know in the initial stages of having it. So let's go ahead and dive in. All right, we're going to start with some etiologies. So these are just terms that you may have heard or been told. A lot of them are repetitive or mean kind of the same thing, but in general, this is not a comprehensive or exhaustive list, but just common terms that you may have heard, like TIA or mini strokes, TBI or traumatic brain injury, CVA, cerebral vascular accidents, aneurysms, infarctions, thrombosis, ruptures. These are all types of things that can cause aphasia, and depending on the type or what the etiology is, it can lead to different deficits. And so here is a kind of a more general breakdown of what causes aphasia. So we have our stroke category, blood clots or ischemic strokes make up the large majority at 87%. Brain bleeds or hemorrhagic strokes are much less. Brain injury, of course, head trauma, brain tumors, infections. And then all of these are causes for what we refer to as acquired aphasia, chronic aphasia, and most especially non-progressive. So when aphasia results as a result of stroke or brain injury, we're not expecting it to continue to get worse or change unless there's further injury. Versus on the right side of the screen here, we talk about etiology or the cause being neurodegenerative disease, such as Alzheimer's or most recently popular frontotemporal dementia, which is going to lead to more of our progressive aphasia types. And when you're educating friends and family or just the public in general, it's so important, as I know many of you know, to distinguish the difference, because it looks very different and it leads to very different outcomes and can cause major misconceptions between chronic non-progressive aphasia versus a progressive aphasia type. So here we are. We discussed that aphasia is a language accessibility issue. And so it makes sense that the injury or necrosis, like the tissue death and brain cell death that happens to cause aphasia, happens typically in the left hemisphere. The left hemisphere is primarily our region that houses the parts of our brain we use to process and express language. Though it is interconnected to different parts of the brain, that's our primary region that houses it. Sometimes those of us that are left-handed, or maybe those of you that are ambidextrous, might have some increased brain activation during language use and processing that's more bilateralized and can be found across both hemispheres, but it's primarily in the left hemisphere. And I like this visual. I saw this actually shared by a person with aphasia on one of their social media pages recently. And I loved it because it kind of looks at just what is happening in the left brain versus the right brain. And so thinking about when you have a stroke or an injury to that left hemisphere, any of these things can be affected or impacted. All right, and so we've touched on everyone is different, everyone's aphasia is different, and I want to be just cautious before diving into these next few visuals. We're going to talk a little bit about aphasia types this morning, but I want to be clear that clinically, I don't really prefer to put people into boxes. And I hope that none of you kind of feel that you're put in a box based on any type of diagnosis that you've been given or specific aphasia type. And why we're going to talk about this more in a little bit later, but aphasia, wonderfully, thanks to neuroplasticity, can be incredibly dynamic, and it evolves over time. It should evolve over time. So even if you receive a diagnosis initially, it's very likely and hopeful that you will not always have that type of aphasia, and that it'll change and as you progress and recover. But in general, I just wanted to share kind of some helpful, nice visual aids for different aphasia types. This one is convenient because it kind of touches on the location in the brain. So if you've been able to have the privilege to see your own brain scans and you get into kind of neurology, it's fun to see where injury might be located and what it results in. We have this beautiful visual from the National Aphasia Association that looks at different aphasia types broken into non-fluent versus fluent, which we'll talk about more in a minute. And a more in-depth flow chart from the Houston Medical Clerkship that kind of shows what aphasia types include intact comprehension skills versus repetition skills, and kind of hallmarks for each aphasia type. So we have a lot to talk about this morning, and it can get a little heavy in terminology. Oh yeah, Denise, did you have a question?
Yeah, I think I had seen somebody wanted you just to slow down a little bit.
Thank you.
And if you wanted to just take a pause, I think there were a few questions that maybe needed to be answered before we move on. Is that okay?
Of course. I'm really glad you brought that to my attention. I'm looking through the chat.
No, I just think, does anybody have a question now before we move on? That was a lot of information at a short period of time. And I do apologize that we don't have the closed caption, but this will be recorded. And in our recording, it will be in closed caption in a more aphasia-friendly recording. So we are doing our best. Again, we do this free and we are learning as we go along. So just be patient with us and we will continue to do the best we can. So thank you all for attending. And if anybody has a few questions right now, we will take them. If not, Kate will move on to the next chapter of her presentation. Thank you.
Yeah. Thank you, everyone. I also should have said at the beginning, please feel free to flag me or someone else in the chat for any comments or questions throughout. And I'm going to see actually if I can, okay, I was going to see if I could share captions, Denise, but I'm not seeing that option. No worries. We were looking at aphasia types, and I actually prefer this visual best. It's through Tactus Therapy. I don't know if many of you have seen it. I'm sure a lot of you have. Megan Sutton is wonderful and provided this beautiful visual that I think does a really nice job encapsulating the fact that though there are set aphasia types that can be diagnosed through diagnostic tests such as the WAB, we really should look at aphasia and what your aphasia might feel like or look like based on kind of different levels of each communication skill. So when we look at language comprehensively as a breakdown of listening and writing and cognition, reading and talking, your confidence, your ability to carry on conversation, word retrieval, all of those different elements make up aphasia, and everyone has different strengths and challenges in each area. And so I think this is just a beautiful visualization of what maybe a better way of thinking about aphasia, especially compared to aphasia severity. I'm sure many of you throughout your medical treatment have received diagnoses given a severity label. And again, I want to remind you that aphasia is always evolving, it's dynamic, it's ever changing, but also it's not a horizontal type deal. It's different based on the different components of language. So you might have a more severe impairment in your speech, but your reading is very minimally impaired or mild. How are we doing? I'm checking the chat really quickly. Okay. So with that disclaimer said, I am just going to talk in general about kind of three main groups of aphasia types. There's many more. Some will say there's 8 different aphasia types diagnostically, but I'm just going to go over briefly these 3 main groups. So this first one, I'm guessing many of you have heard of, maybe many of you were even diagnosed with this initially. Your first few hours or days post-injury or stroke. And so this first one is global aphasia. The hallmarks of global aphasia are impairments in all 4 language modality categories. So difficulty with reading and writing, speaking, and listening. As I mentioned, it's really commonly diagnosed initially. Immediately post-injury or event, your brain has underwent quite a significant amount of damage, and there's immense amount of healing and edema and swelling that can really cause, it can look like further impairment or intense impairment that really will disappear once that swelling and healing starts to take place over the next few months. And so hopefully for many that were diagnosed with global aphasia, it can often improve as the damage to the brain starts to naturally heal in what we call that spontaneous recovery period. For some, if the damage and lesions to the brain are immensely extensive and drastic, they might have resulting global aphasia. But it is very commonly diagnosed initially and oftentimes resolves and evolves into a different aphasia type. Our next really common aphasia type is Broca's aphasia, or what we refer to as a non-fluent aphasia type. And those hallmark characteristics are speech being produced in short utterances or few connected words. Oftentimes, typically comprehension is intact. So one with Broca's aphasia typically has very good ability to understand spoken language. And they typically have reading intact, reading comprehension is intact and a strength. But their ability to combine language into statements and fluent and grammatical sentences is where the impairment lies. And this can be seen in their speaking and also their writing. The next big aphasia group is Wernicke's aphasia or a fluent aphasia type. And the hallmarks of Wernicke's are that fluent and connected speech, where speech might come out with ease. There's not a lot of hesitation or halting. There might be an overabundance of speech. I don't know if anyone's heard of word salad or talking about fluent speech that oftentimes can be jargonous or not make total sense, what we would describe as incomprehensible. But it's very fluid. It sounds like regular intonation and statements being produced. The hallmark impairment for a Wernicke's aphasia or a fluent type aphasia is impairment in the ability to understand spoken language. That's language that is being spoken to you, as well as awareness or comprehension of their own spoken language. And it can sometimes largely impact reading and writing as well. That kind of depends on the person, but oftentimes reading and writing are also impaired. So those are three kind of main categories. As I mentioned, there's several, typically about 8 aphasia types that diagnostically we like to break it down into, but these are 3 main categories of chronic acquired aphasia. The fourth is anomic aphasia. I don't know if many of you have heard of anomia or have been told that you have that. When we think of anomia and anomic aphasia, the primary impairment here is word retrieval, or what we call word recall. And so just as the visual shows, what's that word? It's that tip of the tongue feeling where you can conceptualize what you want to say, but you're having trouble retrieving the proper word or term or name for something. And that can be seen across writing and speaking. Our last section is talking about the aphasia type that is progressive and is a result of a neurodegenerative disease. And so that is referred to as primary progressive aphasia, or PPA. Unlike the other aphasia types, this one is degenerative, so that means it worsens over time. And sometimes that aphasia, that recognition of a loss of speech or language, is the first symptom. And so it can start with looking like anomia. It can start with looking like word retrieval deficits and more issue with retrieving the proper terms and names of things. And it'll slowly progress to a loss of language across modality types. And so diagnostically and treatment for primary progressive aphasia is so very different, of course, than our chronic non-progressive aphasia types or acquired aphasia types, because there's a lot more at play here, and it's as a result of neurodegenerative disease, meaning that there's a lot of other functions that are unfortunately degenerative as well. Okay, that was a lot. We're going to continue with more terminology. This section, most of you probably know, but just in case you hear these buzzwords in your speech therapy sessions or when you're talking about communication, these are kind of some categories that we as clinicians tend to look at, or physicians might look at in terms of communication. So when we talk about fluency, we talk about the ability to make connected speech or the ease of producing grammatical statements and sentences. When we talk about word retrieval, we're talking about the ability to recall a word or a name of something. When you hear comprehension, that's referring to your ability to understand, your ability to process, and that we talk about auditory comprehension or reading comprehension. So your ability to understand spoken language, what you're hearing, and your ability to understand what's written, text, subtitles, headlines. Repetition is, of course, your ability to repeat back something that is said verbally. Not the most functional skill to look at or measure, in my opinion, but for whatever reason, we definitely try to diagnose it sometimes when looking at aphasia types. It can definitely impact a person's ability to self-cue or to receive cueing by being able to repeat back a word that's being modeled for them. So that's, I guess, one reason. We look at automatic speech. So how intact is your ability to kind of have that automatic response to common things that we say or questions, such as, hey, how's it going? Hi, how are you? Thank you, after somebody holds the door open for you, different things like that. And then, of course, articulation. And so when we're referring to articulation, we're not talking about language use or semantics. We're looking at just pronunciation, how you are saying a word, how a word is being executed. And so we talk about that a lot, most often with our motor speech disorders, such as apraxia of speech and our dysarthrias. And we're going to dive into those a little more in a little bit as well. Here's some further aphasia-related terms. I'm going heavy in the definitions first, but I promise we'll get through it. These ones maybe are not so familiar, or maybe many of you have heard or seen about them. I started with our A terms apparently, but the first one is agraphia. And so if you ever have heard of agraphia or you've seen it in your medical records, that is a fancy word for an inability to write or a writing impairment. That goes for typing as well, of course, in our modern day technology, but it's basically any composition of written language. Alexia, this one in the middle, is referring to a reading comprehension impairment. I'm sure many of you have heard of dyslexia, which is really well known as a developmental reading impairment, difficulty with reading developmentally. And so alexia is similar. It's an acquired reading impairment. This last one on top is, I have a hard time pronouncing this one, but acalculalia. And it refers to difficulty with numbers or mathematical problems. So it can look like an inability to complete mathematical equations. This can be seen as transposing numbers. Maybe when you're reading a number or you're hearing a number and you're transposing it in your comprehension of that number. It can be difficulty with adding, subtracting, or working through a real life math problem. On the bottom here, we have anomia, which we talked about already a little bit, an inability to name objects. You recognize the object, but the name for it isn't coming to you right away. And that's in comparison to this last one here, agnosia. And agnosia is not aphasia. It is separate from aphasia, but oftentimes can happen after brain injury or stroke. And agnosia looks like a difficulty even recognizing objects or people or sounds. It's a difficulty in the processing of any of your senses. And so what that can look like is that you experience or you see a photo or you see an object of something. And with agnosia, you might not recognize what that is, even though you can see it perfectly fine. And it's familiar to you. Yeah, Denise?
Don't know if you are seeing some of the questions, if you want to stop and take a look at a few of them.
Yeah.
I don't know if I don't read well, so I just know that sometimes I'll forget this later.
I'm seeing one. Do you ever change the type of aphasia you were diagnosed with during recovery or therapy? And great question, Bill and Donna. Yes, absolutely. your diagnosis can definitely change and should change over time as you progress and recover. Those changes may not always result in you getting put into a different aphasia type or a different box diagnostically, but oftentimes it might. As your aphasia improves and as your communication skills and abilities improve, you might have started with more telegraphic speech as a Broca's aphasia type, and you might become much more fluent. Or you might have a more global presentation with aphasia initially. And as you heal and as you participate in treatment and improve, you might gain some of those modalities back and be more of a transcortical aphasia type or a Broca's aphasia type as you improve. So absolutely that your type of aphasia can change after an initial diagnosis. I'm not seeing any other ones, so I'm going to jump back in. Again, I'm sorry, this is very heavy in terminology, but I hope it's helpful for some of you, as you may have heard some of these terms throughout therapy and wondered what that is, or maybe have never had the time, or maybe a professional has never taken the time to communicate that clearly with you. So these terms at the top are often ways that we describe communication, and mostly kind of communication mishaps or errors. The first one is paraphasia. I don't know if any of you have heard of this term. These are very common after having aphasia. And what that means is a word substitution, essentially. So you might have exhibited a paraphasia when you're communicating and you accidentally said the word orange when you meant banana. These can happen both phonologically or semantically. And what that means is sometimes our brain might pull a word that sounds really similar. That would be a phonological paraphasia. Or sometimes our brain might pull a word that is semantically similar, meaning it's in the same category, it's close, such as orange and banana, but it's not the right one that you wanted. And your brain kind of almost pulled the wrong file out of the right folder. So those are what we call paraphasias. The next one, oops, let me go back here just a moment, is perseveration. This is used outside of just aphasia-related terminology, as it can be seen in any motor task. But in terms of communication, what it can often mean is unintentional repetition of a word, a gesture, or maybe even a movement. So perseveration is kind of thought of the brain like refiring the same neural signal over and over and over, even when the topic has changed or the stimulus has changed, it's giving the same response, almost like a glitch. It's obviously not it's obviously not purposeful. It's unintentional, and it's kind of, I always think of it as like a short firing when your brain is kind of short firing. It's just sending the same signal over and over. And that can look like the repetitive use of the same word over and over. So sometimes we might meet individuals with aphasia who might only say the same word over and over and over again, despite it meaning many different words in their mind. That's the only word that comes out. That can be called a stereotypical utterance, or can be a result of perseveration on a term. It can show up in your writing. So sometimes individuals with aphasia might be writing a note or a message and write the same word 2 or 3 times in a row without realizing it. It might be an inability to move past the first letter, especially initially when there's a lot of injury at the beginning. Perseveration can also be seen in a motor movement. So unknowingly grabbing a cup over and over again and being unable to put it down, even if they're no longer taking a drink. Those are different examples of ways that you might see perseveration after a brain injury. The next one is jargon. And so when we talk about jargon, we're talking about kind of that nonsense words. They sound normal in intonation, and they're oftentimes strung together in sentences. Sometimes they're mixed with real words, but they don't hold any meaning. They don't really make sense. An example might be a person with like a Wernicke's or a fluent type aphasia might sound like they're speaking normally. They'll have function words intact, but have some jargon intermixed. So the example such as, which is similar to the Mengers, if I can dweeze that.
Kate,
Yeah.
there was a question in the chat from Guru. Says, hi, thanks for the session. Caregiver and her husband has brokers from India. If the person is not able to retrieve a word, does it mean they have anomia?
So word retrieval, you can just have word retrieval deficits, and that's basically anomia is the term for that. So if their main deficit is word retrieval, like you were saying, Guru, then it is very likely that you have anomia, or sorry, your spouse. I hope that answered the question. But yeah, anomia is the term for that word retrieval difficulty. Thanks, Ken, for bringing that to my attention. This last one is a neologism, and that refers to a word that's made up and does not have meaning. So calling a toothbrush a slunker or glimbop. Maybe you've heard someone produce these. They sound normal, they have perfect intonation, but they don't carry any semantic meaning. Perfect. Thanks, Guru. I just saw your comment. Okay, 2 more. I mentioned this briefly earlier when talking about Broca's aphasia, but maybe you've heard the term telegraphic speech. Maybe you have heard that the way you speak is the same as telegraphic speech. And we see this typically in our non-fluent aphasia types because of the impairment in being able to connect words together and language together to make a complete grammatical statement or sentence or question. And so telegraphic speech is a fancy word for kind of simple sentences. They typically look like 2 to 3 words strung together, mostly made up of what we call content words, verbs, and nouns, but they might be missing those function words, those prepositions, articles, adverbs, things like that. So many of you, I see you, Trish, many of you, maybe you started out in your aphasia journey with just being able to say, Kimmy, store, milk. This is what we would refer to as telegraphic speech. We can derive a lot of meaning from that, so it's still pretty effective communication, but that grammatical ability to form those sentences is no longer there. And then the last one I wanted to touch on that's also really common is a yes or no bias. I don't know if anyone experienced this, especially early on in their recovery, but oftentimes immediately after injury, you might have what we call a yes bias. So, and no matter the question that you're asked, yes. Or for some people, it's no. But typically, that's kind of a perseveration on the word yes. It's not maybe a true intentional answer. It might be a result of comprehension deficits, but sometimes it's kind of just that automatic reaction to answer with a yep. Are you 2 years old? Yes. Even if the answer or the question is, or the answer yes is very blatantly incorrect. So oftentimes that resolves naturally with as you continue to heal and recover. Sometimes it needs to be targeted and addressed in therapy. And a lot of that just relies on gaining awareness of the incorrect answer or awareness of the automatic response of yes, and being able to kind of self-correct that. Okay. Bear with me, gang. We're going to keep cruising through, and then we're going to have a brain break coming up pretty soon. So this just shows some speechy related concomitant disorders. These are disorders that are really common co-occurring with aphasia, but they are not aphasia, they're separate. And so one of the most common and probably most frustrating types is apraxia of speech. I'm guessing many of you have heard of apraxia. Maybe some of you curse its name. It's that inability to plan and execute speech motorically. So language-wise, you know what you want to say. Maybe even you are able to retrieve the word, but you're unable to produce it articulately or correctly due to motor planning. So your tongue and your teeth and all those articulators that have to so intricately work together correctly and complexly in order to produce that word or sound accurately is not, that motor planning and execution is not there. And apraxia can be pretty gnarly on top of aphasia because you can have language errors, and then you can also have speech errors, and you can have the combination of both of them. So that's apraxia of speech. Another really common motor speech disorder is dysarthria. And so dysarthria is different than apraxia because it's actual result of weakness. It's a weakness in the muscles used for speech. Sometimes it can sound more like that slurred speech. It can be a result of that asymmetric facial droop, right? Maybe on your right side you have that weakness or hemiparesis, and so that can largely affect your speech and also your breath control, muscle control for phrasing, all kinds of different things. So dysarthria is referring to that weakness, sometimes spasticity as well. Whoops. Oftentimes there's cognitive communication deficits. This also is not aphasia, but sometimes if an injury is very vast and extensive, there can also be deficits in memory, working memory, short-term memory. There can be deficits in attention and overall executive functioning. And then voice disorders can also be really common. So I wonder how many of you felt like your voice sounded different after your brain injury or stroke. That can be caused by vocal fold paralysis, where you might have decreased vocal quality or decreased breath support. So again, not aphasia, but a lot of vocal changes, low volume, hoarse quality to your voice that can often co-occur after stroke or brain injury. Okay. I'm not going to go through all of these. This is not an extensive or comprehensive list. It's just kind of like top most common maybe of comorbidities or possible other ones that you might experience. So maybe some of you your speech therapy initially might have looked like mostly treatment for dysphagia or swallowing difficulties. Maybe you were put on a restricted diet and had to practice swallowing and being able to swallow safely. That's known as dysphagia. We talked about voice disorders, hemiparesis or weakness on one side. A lot of individuals might experience visual deficits like field cuts, double vision, blurry vision. Again, not aphasia, but other comorbid issues. Personality changes, mood changes. I don't know if any of you have experienced some emotional lability or a flat affect after your injury. Seizures or seizure disorders can be really common. Incontinence, neuropathy, nerve pain, tingling, and loss of sensation. So all of which are common things that can co-occur. Here's our last bit. Reduce psychosocial difficulties. So maybe you're experiencing more emotional dysregulation, maybe some impulsivity or some irritability. Distractibility. Maybe just in general, you feel your processing is slower after brain injury or stroke. Neurofatigue is very, very real, a very, very common real thing. Something that you will have to cater to or should cater to. Sensitivity to lights, sounds, or smells. And then we already touched on this a little bit, but cognitive impairments as well can be a comorbid issue alongside of aphasia. Okay, that was an immense amount of terminology.
Can we
With
add
that,
one more to it? Can we add one
oh,
more to
sure.
it? Can
Yeah,
we add depression?
yes.
Please add that one.
I should have
Grief.
added it to that list. Our mental health section is coming up, but
Okay,
yes,
yeah,
I
but the
agree.
grief and ongoing grief and depression it's real for all of us living with aphasia.
Very, very true. Good point, Denise. We're going to dive into that mental health section after our brain break, but right now, I think we're right on cue at 10 o'clock. So we are going to take a 5-minute break. I'm going to go on mute. You guys won't have to hear me for a little bit, and we'll meet back at 10:05. Okay, everyone, I'm going to give everyone just one more minute to get back or to take off if need be. How's everyone doing? Are we hanging in, those of you who are there? Okay,
We have 78 still
great.
on the call.
Awesome. Okay. All right, so that part, I apologize, was really heavy with terminology. Hopefully you were able to take some screenshot pictures that you can process at a later time if need be, or share with family or friends or your clinician. For this section, we're going to talk a little bit more about the psychosocial aspect or impact, and where do we go from here? So I have aphasia. Now what? Number one, from a speech pathologist perspective, the biggest issue to tackle and start problem solving is, how can I communicate now? So that doesn't mean, you know, focusing on what you've lost, but instead focusing on, okay, how do I communicate now? Maybe speech isn't accessible. Certain parts of my language are no longer accessible. So first step is identifying what are my strengths and where are the challenge areas, and how can we get creative in being able to communicate and access language in other ways. And it sounds really simple to do that, but obviously it's very difficult and very complex. I saw some of you in the chat saying you got you got all three. You got apraxia, aphasia, dysarthria, and that makes things really tricky. And it varies from day to day. So this is not an easy problem to tackle, but I think one of the most important ones that individuals and families need to kind of work on with their medical professionals, specifically with us speech language pathologists. That's our role, is outside of education and resources. We have to help you problem solve. How are you going to communicate? How do we get that language accessible now? So, first, maybe is assessing what's being understood. After your injury initially, what are you comprehending? Are you able to understand spoken language? Does it need to be combined with written keywords? Maybe understanding spoken language and written language is not accessible, and we need to rely on pictures and gestures at this time. Maybe we need to limit it to just two choices. Maybe there needs to be a lot of communication aids made available in the hospital room so that you can call when you need help with something, you can contact a family member, or appropriately answer a medical question. So looking at what's being understood versus, okay, how can I or my loved one express or access language to communicate? How can they share their thoughts now? Maybe speech is no longer an option at this time. Maybe right now that apraxia is pretty severe. That word retrieval is, man, gnarly. It's getting in the way. So how else can we access that language so that they can communicate their thoughts and their needs? Maybe they need to be given a pencil and pad of paper, and maybe they can write, maybe even the first letter or sound. Maybe they can draw or be given photo options that they can point to. Maybe they're an awesome charades player and gesturing is the name of the game right now. Maybe that's how our best way to communicate is at this time. Most likely, it's oftentimes a combination of a few of these. And then a lot of back and forth with their communication partner in asking clarification questions and ensuring that accuracy of the conveyed message. Something that's really important at the initial stage to acknowledge is that the person who's had the injury or event occur may not realize what their communication sounds or looks like right now. So to them, they're waking up and they're thinking they can communicate just as they normally did before. And unfortunately, that's no longer the case. And so a really important part, I think, in the initial stage is acknowledging that as the person with aphasia, they may not be familiar or realize what their communication looks like, what their impairments are. And as professionals and as family members and care partners, we need to tread very lightly, not to crush any hope, not to give any unrealistic expectations that they'll never speak again or their life will never be the same, but also acknowledging when you're not understanding them and letting them know, hey, I'm here to work through this with you. This is probably the toughest thing you've ever gone through. How can we figure this out together? So bringing awareness, because that awareness may not be there, especially initially, and maybe even years later for some. But also working with them to problem solve, or what I would say, get creative. So let's find some creative communication, AKA multimodal communication, AKA conversation and communication training with your partner. Multimodal communication is going to be the make or break after having aphasia or apraxia or dysarthria, because all of those modalities are no longer accessible. That the thought and the knowledge is still there, but that language just isn't, unless you find a new pathway to take. So there's a lot of ways that people kind of describe to others what aphasia is like. Maybe some of you share with your family that it feels like waking up in a foreign country where you don't understand or speak the language, and now you have to get creative and use gestures and pictures and signs. In terms of thinking about rehab and recovery, I like describing aphasia as your brain is like a highway, like a huge, massive highway with tons of pathways and lots of traffic. And when you have that brain injury, you've got a major disruption. So you have to then find alternate routes and detours. And that's what happens in rehab, basically. Our job is to find new pathways. Thanks to neuroplasticity, we have neural reorganization. So our brain, the more that we do tasks, we engage in conversation, we stay active, our brain finds new pathways around the areas where we have brain cell death and damage. And we find new pathways where there's good brain, where there's healthy brain. And so our brain learns to reorganize where it can form new neural networks. Rehab requires some creativity when it comes to communicating with one another after having aphasia and apraxia. So finding those accessible pathways and capitalizing on those strengths. And the important part, the rehabilitative part, is using those strengths and pairing it with the modalities that aren't accessible. The highways that are broken down or have damage or construction currently, pair them with those strength areas so that we can regain some of that comprehension, or we can regain some of those challenging areas and combine it with pathways or modalities that are accessible. I'm a huge component of using compensatory tools and strategies. I know this can be a big preferential, a person's preference. Some are just determined to grit through it and rehabilitate a communication skill. And others are okay with using compensatory tools or learning strategies to kind of to compensate for a difficulty or an impairment, or to get around and still improve their function by just doing things differently. Having support finding support, whether that looks like family, friends, loved ones. It can be emotional support, physical and logistical support, like managing appointments. How fun is it to have aphasia and have difficulty with numbers, dates, and times and managing a whole new slew of healthcare medical appointments? Um, it's so important to have support with transportation. Oftentimes, driving is not an option after having a stroke or brain injury, especially with seizures. So, whatever that looks like, whatever those needs are, it's important to identify them and seek out resources and supports for those. And then, of course, giving yourself grace and having patience. I personally cannot imagine, I don't have the experience of having aphasia, and I can't imagine how frustrating that must be to have that loss of yourself and that loss of that ability that you had before, a whole lifetime of ability that now has been taken from you in many ways. And so rehabilitation takes time, and it takes a lot of patience from the person who's experiencing the loss and also their family members and loved ones who are also experiencing loss. So here's our, you can think of that, those neural pathways that are under construction. And our job is to find alternate routes, find the detours and capitalize on them. Keep moving. Don't get stuck in that backup. A lot of times, I'm just going to touch on this briefly, but we think of rehabilitation as restorative versus compensatory. So restorative is literally restoring or rehabilitating an impaired function or a skill. That's oftentimes addressed in speech therapy or any of your therapies, physical therapy, occupational therapy as well. It's improving that ability to walk without a walker. That's restorative. To name objects without using a tool, that's restorative. Versus compensatory. So again, using a strategy or a tool to compensate for that deficit. And Susie, I saw you put in compensatory tool. Thank you so much for putting that in the chat. So what that might look like is maybe as a person with aphasia, I want to get back to texting, but I still have a really hard time being able to type sentences or even type words. And so I might use an app that has a preset of phrases or texts that I can just click a button and it'll show up on my phone. Or it might look like the use of a picture book with the photos of my family members and loved ones whose names I have trouble saying, but I can quickly just point to them in my communication book. Those are pretty random examples, but those would be considered compensatory tools. So you're not stuck if you can't say the name of your cousin, but you can just quickly point to her picture in your book to communicate that they're going to stop by later today. That would be a compensatory tool. All right. These are just some like really basic, general, non-personalized goal ideas, but ones that just some thoughts. This is more for the professionals in the group who maybe are or will be working in the acute care setting on when someone has just had a major life event and crisis, what are some functional communication tasks that we could work on to help improve their quality of life right now? So being able to call the nurse or call for help, ordering food by phone, or maybe they need to be able to order it in person. Maybe they need a modified like paper menu with pictures that they can just point to. Being able to understand medical discussions. I know most of you have probably had the experience of being checked on by a nurse or a CNA, and then the neurologist, and then the, X, Y, and Z, the respiratory therapist every 2 hours, and you're getting loaded with tons of information. And being able to understand and participate in those medical discussions with your care team should be a very top priority. Being able to communicate with a family member or contact them. Increasing awareness of your impairments. So like we talked about, a lot of times they're just the person who's had the stroke or brain injury is just waking up and have no idea that their communication has been stripped away from them. So increasing awareness of what's going on, and then identifying those best ways to communicate. I'm going to dive into some sad truths just momentarily, but we'll have some good news to follow. I'm sure many of you have experienced this yourselves, but here are some major challenges and setbacks in our medical practices currently. Probably most depressing and a fix that is ongoing is that our medical facilities and staff are not aphasia accessible. This varies so greatly based on the facility that you're at. I hope many of you have had positive experiences with some of your healthcare workers, but I know that there are many who have not. And so it should be a standard, as communication is a basic human right, that medical professionals and staff should be aphasia trained. They should be knowledgeable on how to communicate with various types of aphasia, various impairment types. Medical information and the process through the system should be more aphasia accessible. And this leads to probably the most safety risk during the acute phase is a lack of aphasia accessibility or awareness. And like I said, it really varies. And this is something that I know a lot of aphasia powerhouses have been promoting awareness in the medical systems, training incoming nursing students, training medical professionals, getting out there and talking to your local hospitals, just like Just Ask does, about aphasia and what you can do to improve patient outcomes. The next hard truth is when you find out that aphasia is chronic and just how much it affects all aspects of your life. I don't need to tell this group that. I know you all live it, but that can be one of the hardest truths, that when you're initially told you have aphasia and you're experiencing it, to know that it may, you're not just going to go back to being able to speak as easily as you used to, can be pretty devastating. And then the next largest is that lack of community awareness, the lack of public awareness in society, which then, of course, leads to a lack of resources and support. So those misconceptions about intelligence and communication going hand in hand, the embarrassment, the lack of being able to return to work, financial hardships, broken friendships or lost friendships due to misunderstanding of how to communicate with someone with aphasia. Tough stuff. These I'm just sharing. I thought these were really telling. They were some comments recently on a social media thread in one of the aphasia, a large aphasia group that I'm a part of. And some of these family members shared things like another minor surgical procedure for my husband, yet another major lack of understanding aphasia by the medical team. Thankfully, the nurse who was getting him settled took us off to the side where it was quieter and explained everything to both of us after we gave her a crash course in aphasia and how to successfully communicate with my husband. I remain frustrated by and hating aphasia 3 years and 7 months later. And these are just some like quick examples, but there was a slew of replies of similar experiences. You know, I explained over and over about her language difficulties, told them to write keywords down. I'm going to make a formal complaint. She received awful care. Good, as they should make a formal complaint. You know, society being ignorant is one thing, but medical professionals is so unacceptable. And sadly, I hope many of you haven't experienced this, but I'm sure many of you have at some point in your medical care. And it's really a disservice, and something that the speech pathology team as a whole should be doing a better job. That's our role. You know, SLPs, we should be the gatekeepers for patients throughout any phase, but especially in critical care. We need to do our due diligence about making sure that any medical care team member that is treating a patient with aphasia knows how to communicate with them, and that it looks differently for every patient with aphasia. And that, you know, the physician just can't come in and rattle off a bunch of terms without using some visuals or writing down keywords. It's not acceptable. It's not appropriate, and it needs to be changed. And there's a lot of awesome aphasia advocates out there who are doing great work, like Tom Broussard and a lot of other organizations who are really promoting awareness in the medical systems and making sure that communication and that human right is upheld. Okay, the good news is coming. Here's the last sad truth part. So Denise touched on this earlier. Here's just some kind of quick facts. Less than 1% of the aphasia population, according to Townend et al. In a 2010 paper, so it's a little bit dated. I think there's new stats coming on the way, but less than 1% of the aphasia population receives any direct treatment for psychological distress. Less than 1%. That's terrible. People with aphasia continue to remain one of the most underserved populations in terms of mental health and counseling services. And this is a huge deal for many reasons. But in terms of just looking at communication, we know that negative emotional states affect language performance. So we know that in general, our semantic lexical processing, and specifically for persons with aphasia, the ability to process meaning in language is largely impacted by negative emotional state. So if you're feeling some really strong negative emotions, your communication is going to decrease. It's going to get worse, which makes sense. I'm sure many of you have experienced when you're under stress, when you're with someone who's very impatient, when you're sad, when you're scared about the future, your communication deteriorates, right? It makes things worse. So what does this mean? Most, I would say, PWA experience some type of mental health crises across their journey, such as depression, anxiety, unconventional grief. I know many of you have probably talked about this before, but that looks like the grief or loss of someone who's still living, right? The person's still there, you're still you, but you've lost a lot of your ability that you had before. You've lost so much. And so that's what we refer to when we talk about that unconventional grief. There's a lack of access to receive mental health supports. So not only is there a lack of mental health professionals who know how to do treatment with someone who doesn't communicate like with just speech as they normally would. There's a lack of resources in general, and a lack of access for people with aphasia to access the very limited amount of professionals who are aphasia aware. And then, of course, when you are impacted by negative emotional states, and that impacts your ability to communicate and access resources, it's a pretty nasty, vicious cycle, right? So, we've got a lot of crisis going on. There's been a big upturn in the aphasia community and professionals, interdisciplinary professionals who interact with persons with aphasia that are really trying to make a change. Big organizations like Stroke Onward are promoting mental health resources and doing trainings for mental health professionals, trainings with speech pathologists to have more experience with counseling, so that we're slowly, not fast enough, but working on getting more resources available and access to the mental health support that is drastically needed. Okay, here's some good news. So, I've said it about 5 times today, but as we mentioned, aphasia evolves over time. So, what you experience initially, even in that first year after stroke or onset of injury, it's going to change. It's going to change due to natural healing, edema and swelling improving, your sensory and processing improving. Um, it's gonna change. And I was kind of being funny with this guy, say no to plateau, but this goes hand in hand with, I think it's a lot of medical professionals are taught to kind of give realistic expectations. However, um, there's no such thing as a end of recovery period. There is something called a spontaneous recovery period that many medical professionals will reference that talks about how the most healing, physical healing, improving of physical injury will happen in that first 6 months, but that does not mean that the recovery ends after the first 6 months. That's just referring to the rapid healing that happens during that time. And so a lot of times you'll see a big burst of rehabilitation in that time, but you can continue seeing rehabilitation for decades after. It's been so cool meeting people who have lived with aphasia for 22 years and hearing how their emotions and their abilities have changed over that time drastically. I'm sure roller coaster ride, right? So no matter what, say no to plateau because aphasia can always evolve. We talked about rehabilitation and use of compensatory strategies and maximizing your recovery that way. And also, the aphasia community is amazing. I think from the past 10 years of my career, I've met the most incredible people living with aphasia and their families. And so you may not have wanted to be a part of this club, but there are some pretty awesome people that are part of the club with you. And the key is to finding those groups and supports and networks so that you can be a part of that community and benefit from the resources. So here's just kind of some key questions and the acute phase. Maybe things that you want to ask your speech language pathologist or some of the medical team staff, the care team, especially before you're discharged. There's a lot of decision making that happens, and there's not always accessible language being used with the patient themselves, which is such a disservice. So as a family member or care partner, and as the person with aphasia themselves, if they can communicate this, it's so important to ask about what the plan is. Establishing what the best way to communicate with the person with aphasia is so that that can be spread to their care team and their loved ones. What are my options after leaving the ICU? Most people will go to an inpatient rehab, and after that, are they headed to like a subacute care rehab, a rehab hospital? Are they getting discharged home and the family needs to find supports for a number of different things in the house? Where can I find more information and resources? How can I get support with? There's numerous examples of things that you might want support with. And so these are all questions, key questions that you can ask. And I didn't come up with this. I've heard so many creative and awesome ways to communicate with care team members, because you can't always catch them. You know, people can't be in the hospital all 24/7. And so I've heard of some great ways of like leaving a notebook at the patient's bedside for the family to write questions and comments and share information maybe about the patient's favorites or interests or about them, you know, in their career. And it's a way that you can communicate with the care team without having to actually catch them face to face. Thought that was a great idea. I've heard of family members requesting the like nursing staff or care team to have signs on the door, big signs notifying that this person has aphasia and how to communicate with them. I've heard of great ideas of doing trainings from the hospital room with family members and friends, getting friends and family educated on what aphasia is and how to communicate with their loved one really early on in the recovery process, so that it doesn't seem as scary, which is silly that it would be scary to the person who doesn't have aphasia. That's kind of ridiculous. But a lot of people who don't know what aphasia is like find it intimidating, and so they need to be educated. Continue to have conversations, continue to interact and be there. That's how you can support us best. And then, you know, finding resources and not being afraid to ask questions. Question the medical staff. Call them out if they're doing a disservice and only communicating to the care partner and not the patient themselves. We always require feedback, and it's how we change and it's how we improve. So it's so valuable the insights and the feedback that family members and patients can share to their healthcare providers. All right, we just talked about that. So in finding resources, these are just a few like really quick, broad organizations to get you started. There are so many amazing aphasia communities out there. And since COVID, most people have transitioned to virtual. So they're no longer having to scrap and find a local regional resource. As long as you have access to internet, you can find some type of aphasia community out there who's wanting to support you. The National Aphasia Association is a huge hub. I think Mara, the newly appointed executive director, is doing a fabulous job at making things more aphasia friendly and just providing more access to individuals and organizations and support as a whole. If you go to the NAA website, you can search. This is for the United States, by the way. I know there's a few international viewers, so I apologize in advance for that. But in the US, you can go to the NAA website and look for a specific provider. You can look for groups, aphasia support groups, other like events or ongoing webinars that they host frequently. There's so much out there. And so they also have a lot of beautiful resources for educating others about aphasia. So that would be kind of a first stop that I recommend to families. The Aphasia Institute, which is actually based on, is out of Canada, is also another great resource. They have so many wonderful like trainings and resources for family members and educating others. If you're on social media, Aphasia Recovery Connection is a massive group that is uniting people and families living with aphasia from all over the world to join together and just connect. helping end isolation, helping others feel not alone. They offer virtual connections groups every day, multiple groups a day. Some, they're not for everybody. They can be a lot sometimes, but for many, it's a great way to connect and practice your conversation skills. And they're free, which is amazing. Aphasia Access is more for our professionals in the audience. Aphasia Access is an incredible organization that is providing better education, resources, and materials for the professionals who are treating and working with aphasia. And they're trying to do a better job at making sure that, bad therapists don't exist. They're trying to make sure that every therapist is being much more aphasia aware and knows how to prioritize life participation goals and working on stuff that actually matters to people with aphasia. I touched on National Aphasia Synergy earlier. This is another nonprofit led and founded by persons with aphasia, and they're striving to spread awareness and also connect and be a support for persons with aphasia. And Voices of Hope for Aphasia is another group that's offering some wonderful services, both locally and virtually. So these are just examples. These aren't an extensive list, but sometimes just doing a Google search is the best way to find local resources. You never know if there's a support group near you. So Google search can be friendly also. So teaching others about aphasia is so important. And so the next few slides, I'm just going to share some resources for doing so. This is a link to a really lovely video by the Aphasia Institute that talks about how to converse and talk with your family member or friend with aphasia. There's so many different wonderful resources out there. These are just like a select few. But this one's easy to share, it's free, and you can download a pamphlet to share physically with staff members or of your care team, or you can send a link to family and friends. The Voices of Hope for Aphasia has aphasia simulations, which can be kind of a intriguing way for family members and friends to understand what aphasia feels like. So there's simulations to kind of really show what aphasia can look like and feel like. Here's a couple others. The American Stroke Association has a nice handout that can be found at this link that talks about stroke and aphasia. It's kind of just a nice comprehensive visual aid that, again, you can pass out to your social networks about stroke and what aphasia is, what it's like to have aphasia, what's the difference between aphasia and apraxia. Another nice resource is this cool book by Tom Broussard called The ABCs of Aphasia. I don't know if any of you have seen this, but it kind of offers what we talked about earlier, an extensive kind of list of terminology associated with aphasia and what that means. The UNC School of Medicine has an awesome site of resources. And if you look down here, I don't know if you guys can see my cursor, but if you go to this link at the bottom, there's a tab that shows aphasia-friendly print material. And this is just like a screenshot of some that are offered, but there's a long list of all kinds of different visual aids and supports for conversations and they are aphasia friendly. And so it's so awesome. They had some on like self-advocacy, informed decision making when leaving the hospital, how to find mental health support, how to talk with your care team about transfers. There's all kinds of stuff. It's a really, really nice resource and it's completely free. And so all you do is you can go on this site and look at their list and click on one, and it downloads on your computer as a PDF. So you have immediate access to it. Really, really lovely, awesome resource. Okay, how are we doing on time? Okay. So, before I go into our takeaways, just a recall that most of you probably don't need, but most people don't know what aphasia is. So we need to educate them. Um, most of our friends and family and support want to be there to help, but they don't know how to help. So again, we need to educate them. And obviously, aphasia can be an invisible disability for many who don't have, the physical impairments associated. They look like they're perceptibly fine, and obviously that's not true and can be so frustrating. So I encourage you to never be afraid to advocate for yourself. I'm going to cruise through these takeaways. So for all of you out there who are living and thriving with aphasia on the call today, recognize that your aphasia changes. It gets better. There is no such thing as a plateau. You are still you. You're still knowledgeable. You still bring so much value. It's communication just looks different now. Life is going to look very different now. And so it's important to find peers. It's important to find others who, your aphasia may be different, but at least they know the experience of what it feels like to lose that part and those parts of yourself. And just some hot tips from some individuals that I've worked with. I think it's really valid and important to record yourself throughout your recovery. So sometimes this can be painful to see really hurtful moments of crises, especially initially after a stroke or injury. But when you're the one living it, it's hard to see change and progress. And so it can be really valuable and important to reflect on how far you've come. It may feel like it's taken a million little steps, but I guarantee others around you notice, even if you don't. So I think it can be really valuable for some to record yourself throughout moments of your recovery so that you can reflect on the progress that you've made and see the differences and see the change. It's so important. Trying new things. So just because you didn't have to do something before doesn't mean that it may not work great for you now. Again, this is kind of referencing like trying out new strategies for recalling different words, for being able to write an email, for understanding a conversation with your doctor. Maybe you want to try that new app that takes notes and dictates for you. Don't be afraid to try new things. You might find that it's your new best friend and your awesome new weapon of choice. Advocate for what you need and accept help. And keep going. Oh, my writing didn't save on that one, sorry. But it's important not to stay stuck in that traffic lineup and back up and on that construction highway. Find alternate routes and support to keep going. Okay, for our care partners of the group, likewise, you have experienced loss and that unconventional grief as well, and so seek and accept help. The person living with aphasia is not used to living with aphasia, and you are not used to living with someone who has aphasia. So not only can that be incredibly overwhelming, but it's a new and scary territory for everyone. So accept help, seek help, be advocates. For a lot of people with aphasia are not able to advocate for themselves initially due to those communication barriers. And so you need to be their voice. You need to advocate and help them gain their voice back. Ask questions. I'm sure many of you have heard the squeaky wheel gets the grease, and that's so true in the medical system. You may not be able to be there present all the time face to face, but those patients who have people constantly asking questions and being present and being involved are going to get better care. So that squeaky wheel gets the grease, speak up. especially if they're not getting the care that they should be. And give yourself grace. It's a learning curve for everyone. You don't know what aphasia is like or what your loved one is experiencing or your friend. And so give them grace and give yourself some grace and time to be educated and learn from them. This is a kind of cool resource from the ASHA Leader. It talks about how to counsel the caregiver, and it breaks it into moments of time throughout the recovery process. And it kind of highlighted what their thought process is during that time. So, you know, in that first year, especially, it's a lot of survival mode, a lot of sadness and loss, and just being concerned with making it through to the next day. Are they going to live? Are they going to survive? Will they go back to work? How can I do this with my loved one? How are we going to afford this? It's crisis and survival mode. And then the next section kind of has some transition. And I know that the next few Saturdays are going to talk about that, so I won't dive in too much, but I thought this was a really nice resource for how caregivers might be feeling in the prominent like themes and concerns throughout each phase. There's also some great free guides to aphasia or a caregiver guide. This one is accessible through the NAA. There's a lot of different books out there. These are just a few that I thought were pretty resourceful. And then for those of you who are healthcare workers or professionals on the call, hopefully you're already well versed in aphasia, but just as a recap or takeaway, we have to do our due diligence with providing education, resources, and materials, not only to our patients and to their families, but especially to our colleagues and our interdisciplinary professionals. We have to go beyond the check boxes of productivity and really capitalize on what these families and patients need now. What's going to make the biggest impact now before before they leave and get transferred to the next part of their recovery phase with new professionals. Maybe that looks like giving them resources to physically give to their next set of professionals that they work with, so they don't have to go through the battle of educating all over again. You can help them with that. And I thought this was really important to think about as well, is that, these are moments of crises, and there's so much happening at once that we cannot expect as professionals that just because we used the word aphasia once and talked about aphasia and had one conversation about aphasia means that any of that information was processed or taken with them. So care partners and families need multiple repetitions of information in order to truly process and understand it. And we also need to provide it in more than just verbal. We need to give it written. We need to give resources visually while also talking about it so that they can reference it at a later time. Patients are in survival mode. They may not even be able to process any type of information at that time, and their families as well. So it's so important to give resources and repeat that important information over and over again across the recovery spectrum so that they have access to it later on. And of course, aphasia is chronic, so we need to make sure that we are really taking into consideration that effects of aphasia are long lasting and that the needs often persist for the remainder of their lives. So how can we set them up for success at each phase? Okay. We kind of talked about this, but yeah, just the difficulty that care partners have not having heard the term aphasia before. Having access to resources can be difficult and daunting and really overwhelming. So we need to make it organized and easy for them. And we need to provide adequate information to our healthcare workers as well. All right. I haven't checked the chat I am going to now open it up for some discussion, comments, and questions. So maybe some of you want to share your best tips or just your experiences at the start of your aphasia journey. And we can take that time to answer questions now and share some comments.
Well, first of all, I'd like to say thank you. This was so educational. I have learned so much. I mean, it's been many years after my stroke and living with aphasia, and you've educated me on so much that I didn't know before. So thank you, Kate. This is great. And I'd love to see people ask questions now. We do have some time to do that. But if you have to leave now, I understand. This will be recorded, and it's open.
Awesome.
Thank you, everybody, for attending. We could not do this without the support from Rhode Island Department of Health. They collaborated with 2 programs this year to make sure that we were able to do this, and with a little help from our friends at NAA. Thank you all. I am so excited about all these presentations we've had. And Kate, thank you. This was so helpful. I learn something all the time, and thank you all for what you do. I'd like to say that we are looking forward to our next presentation. It is Carol Dow Richards, and then she will be presenting the priority about care partners. So I am so looking forward to seeing you all next week. And do your best to go out there and educate somebody about aphasia this month.